Greetings and a warm welcome to the Comfort Corner, a palliative care series on OncoDaily. We aim to raise awareness about the critical need for palliative and supportive care among cancer patients with the goal of improving their quality of life. Our motto, navigating life twists with compassion, encapsulates our mission. My name is Martin Harutyunyan. I'm a medical oncologist / palliative care specialist from Genolier Hematology and Oncology Center, Yerevan, Armenia. I'm honored to introduce the pioneer guest of our series, Dr. Matti Aapro, a renowned medical oncologist who has made significant contribution to cancer care. Dr. Aapro is a president of SPCC and the past president of European Cancer Organization. He is also a board member of many well-known oncology organizations such as UICC and the President of All.Can, reflecting his commitment to cancer care and policy advocacy. His primary interests include new drug development, breast cancer, geriatric oncology, and supportive care. I could list his achievements for hours, but we'll have to save that for another time. I had the pleasure of meeting Dr. Aapro 1.5 years ago during the ESCO's mentorship program, and he has been my mentor ever since. With his support, we launched a palliative medicine series at Genolier Hematology and Oncology Center just 1 month ago. Hi, Dr. Aapro. We are very glad to have you with us today.
Hello, Martin. Thank you very much for having invited me, and compliments, because the work you have done with some support from me and many other colleagues of the world in the past year, and now you have an official commitment in Armenia to develop support in palliative care in your center. This is the beginning of the journey. I will be there, and many others will be there to support you during this journey. And I'll be happy to discuss some topics with you. Just go ahead and ask me the questions. I'll try to give the right answers.
Thank you very much. Many of our listeners might be confused by the terms supportive care and palliative care, as they often come up in discussions. Can you help us to understand the main differences? And as an expert in the field, how would you define supportive care in professional context?
Let me start with the last part of your question, which is what is supportive care? I'll give you the perspective of the Multinational Association for Supportive Care in Cancer, MASC, of which I've been the president quite a few years ago. And we had this discussion already more than 20 years ago on what is this all about. And basically, supportive care is everything you do to help the patient and those around the patient from before a diagnosis, i.e. helping people to have a lifestyle that will decrease the risk of cancer, to after the diagnosis, to the wonderful end of cure, which does happen more and more often with cancer, or the unfortunate situation that the patient is going to die. And we should never forget that it is not only the patient, it is, as I said, everyone around the patient, those that care for the patient directly, and those that help the patient, not being a professionals, like their friends and their families. We have to give support to them. Palliation is a specific term for a part of this work, which is to decrease the effects of the cancer on the patient. Specifically, often people think of palliation as pain treatment. It's not only pain treatment, it's also many other things around it, but it's part of supportive care. There had been long discussion about this. They continue still nowadays. There's a very important position paper of the European Society of Medical Oncology that is available online in Annals of Oncology. There's a wonderful paper in Lancet Oncology led by Professor Stein Casa, one of the leaders of the field of palliative care. And there are many other editorials. I think that should clarify everything for everyone. The most important point is we all do something to help our patients. Call it whatever you want to call. Let's do it well.
Thank you. And continuing this topic, I'd like to know, how did you decide to focus on geriatric oncology and supportive care?
Well, it's very simple. As all things in our life, it's determined by where you are, what happens, whom you meet. I went into supportive care when I was a fellow in Tucson, in Arizona, with, among others, Professor Dave Alberts, who unfortunately passed away last year. And Dave had patients receiving cisplatin treatment. And in those times, the idea was, well, too bad that they will vomit a lot, but we cannot do anything about it. And I happened to stumble on the paper, actually a letter in the New England Journal of Medicine of a colleague, Dr. Baker, who said that he had observed in the treatment of Hodgkin's disease that in the cycles with prednisone, there was less nausea and vomiting than the cycles without prednisone. So I just thought, well, why don't I try dexamethasone for these patients? It did help. And that's the way things started to go. And then many colleagues joined. And among them, I have to cite, of course, Richard Grella and Rudo Navari and many others who are members of the MASC ESMO team that comes out with the new guidelines for nausea and vomiting, which just came out in January of this year. And then as things went on, as you know, geriatric oncology is our daily life. A lot of our patients are of the so-called geriatric age, i.e. age above 65. We all know that that is a wrong determinant. The real determinant is who the patient is, what are the comorbidities, and that will change or will not change the way of treating the patient. And here I must say, I met Professor Ludovico Balducci, who has recently retired. And Ludovico is the leader. He is the one who really started moving the field, along with B.J. Kennedy, who was president of ASCO a long time ago, and whose name there is a prize now at ASCO for geriatric oncology. So I helped the team around Ludovico, and then we created the International Society of Geriatric Oncology, and that's the way things went. It's very simple.
Thank you. Your work has undoubtedly influenced global oncology. Could you share how your leadership roles have helped shape international policies and care standards?
Well, it's not my leadership. I'm one. I'm one of those. I've cited several names. I could cite a long list because I believe in collaboration. I believe in the fact that we always find when we have an idea that in which we believe in, some other people that say, oh, yes, that's a good idea. And sometimes one of these persons actually will take the lead in that particular idea. Wonderful. The important point is that the idea goes forward. So we work together. That's why I helped create the Multinational Association of Supportive Care in Cancer a long, long time ago when Hans-Jörg Sen started it along with Jean Klastersky. And then I started the International Society of Geriatric Oncology, and I have helped start other entities working together. That's where we can influence. It's not one person. It's many voices saying the same thing in different ways, because of course we speak in different environments. You cannot say the same thing to the health minister of Armenia as I can say to the health minister of Switzerland. The environment is different, but we pursue the same idea and then we adapt to the reality of the different countries.
With the rapid advancements in medicine, what are your predictions for the future of supportive oncology, and how should we prepare for the next wave of innovation?
Important question, Martin, because the enthusiasm, correct enthusiasm for some of the new treatments that we have have put aside again a little bit supportive and palliative care. People say, oh, well, we are so excited. So you go to a main meeting, like let's say the ESMO meeting, you'll have 2,000 people in the room where they discuss the latest about immunotherapy for cervix cancer, which is the disease that is unfortunately quite rare in Europe, but unfortunately quite frequent in many other areas of the world. And you'll have a much smaller room, half filled by people discussing the latest news about controlling the nausea and vomiting related to, for example, antibody drug conjugates. These are fantastic achievements, but they do have their own side effects. And it will be the same as we learn more about, for example, vaccinations. We are developing, we know, various vaccine treatments for cancer. And vaccines, as we all know, they have their side effects. We have to learn about them. And we learn also about side effects that we never thought of. So it's an always evolving field, what I never thought of. Years ago, I had never heard, well, of course, we had all heard at medical school about hypophysitis, but I've never thought it would ever happen. And now we know that there are some immunotherapies that are related to hypophysitis. We have to know about it, we have to know how to react if it happens to the patients. So there's a future for supportive care as well. And it is very important that we are there in order to allow the best possible way of using the new treatments and doing what Dorothy Keefe, past president of MASC a long time ago, now president of Cancer Australia, said, supportive care makes excellent cancer care possible.
Yeah, you're right. What advice would you give to young professionals who aspire to make a global impact?
Well, my recommendation is to do what I have seen. Those of us that have done something, as I said, most of the times all together, is that we first find our friends, find our team, find those that can help us. And then to do that, we have to be heard. We have to be not sitting in the back of the room, but be sitting in the middle or in the front of the room, raising our hand, asking the right questions. And this will sometimes lead to the fact that the speaker, a very distinguished person, a fantastic researcher in a very specific field, but who has a huge knowledge and has lots of contacts, will say, can we talk about with you after the meeting? I would like to hear more about you. And that's the way you start. That's the way you influence. And once again, not alone, have your friends around you. Don't be shy.
Thank you. And the last question, with your extensive roles from clinical work to leadership and patient care during their most challenging moments, how do you balance your professional responsibilities and your personal life?
Martin, many in this world are overwhelmed with work, and certainly those in healthcare are. But we have to think also of ourselves. We have to realize that many have burnouts, and often these burnouts are because they want to do the best, but there's a limit. There's a limit to what a human being can do. And this limit, we have to find it for ourselves. Some of us can do more or less during a 24-hour day, but we should not forget the day is 24 hours. It's not extensive, okay? And then we have our interests, we have our friends, we have our families, and we have to take the time for them, the time to be with them, because they will recharge our batteries. They are those that will help us to continue. And this is a very precious time. And this time we have to carve it out. And again, we have not to be shy. If, for example, speaking to the younger generation, those are still to be on call first line. I remember the times that we were discussing and fighting about who is going to be on call for the Easter weekend. Well, you have to say that I'm so sorry, but I have planned with my family an Easter weekend vacation already 3 months ago. Tickets have been booked. That's it. And by the way, I was on call last year, so someone else is on call. Don't be shy. Say the right things. But before you say that, make sure that you have someone who is going to say, then I will take it over. And then you say, thank you. Then maybe I will take the time to Christmas.
Thank you very much for your insights.